Welcome, everyone. We're going to take a minute here as people are hopping on pretty rapidly. We want to just say thank you for joining us. And hopefully, we're going to have some good information that you can find of value and benefit and applicability to your marketplace. Um, we've got kind of an informal time. If you want to pose a question, I would suggest doing that in the chat or the Q&A section, and we can make sure that we follow those along and get to them likely at the end of our time. If for some reason we run out of time, we will make sure that we get responses with regards to those questions, and we'll send that out by email to everyone who is joining us. Um, Joining me this morning in this great presentation is my good friend Trevor Dare with Granite Peak Analytics. And we're real excited to be able to talk about something that we both enjoy a lot, which is what's happening in our state and federal legislative areas. Trevor, you want to give a welcome?
Yeah, thanks everybody for joining, especially on a Monday. There's nothing better than not just pharmacy benefits, but let's talk legislative events, right? So happy to be back on a webinar with you, Lisa. I think we had a lot of fun last time, and um, with the fun also came, I think, some good education and some nuggets that we can hopefully educate the ecosystem on, and uh, really look forward to kicking things off and starting to talk a handful of states and what's been done legislatively, and then talk about the executive order from President Trump and, just kind of pros, cons, and all the good stuff. So I
That
don't know if
sounds
I
good.
love the legislative pieces. I do have a passion for pharmacy benefits, but this has definitely become a bigger piece and part of it.
Big, 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 big. Let's jump in. We're going to hit some state activity first. And again, keep in mind if you have questions as we go along, either the Q&A or the chat's the right place to put those. We'll have Emily field those for us and to be able to tee that up toward the end. So a couple of quick hits because there are some things that have been happening that actually have came about since we kind of put the plans in place for this event. So um, again, just quickly to mention some things in some other states. So Alabama has a Senate bill that was started there. It was actually signed into law and is going to be effective in October. And it basically is taking aim at unfair PBM fees and the ability to steer patients to PBM owned chains. So, as we will see with several states that we're going to talk about today, there's a lot of activity on reimbursement from PBMs, and this logically, I believe, comes from the fact that the pharmacy industry, especially the independent pharmacies across the country, they have been hit hard, and many have been forced out of business. So, the pharmacy industry has risen up and they have grabbed the ear of their legislators. And so in the state of Alabama, there is a reimbursement mandate now and dispensing fee. So it's equal in that state to what the Medicaid program receives. So basically, it's an acquisition cost pricing model. NADAC is another phrase that I think might be heard in reference to this. Also, there's a ban on spread pricing and requiring pass-through rebates. So some good things happening there. And again, Alabama is kind of one of the states that is joining in on several of the things on this bulleted list that we've seen happen. Colorado, there's a House bill that has been sent to the governor. I don't believe it has had signature yet. The last time I looked, anyway. This is regarding PBM revenue, requiring it to be from a single flat dollar service fee per prescription, and for that to be transparently expressed. So, PBM revenue, which is a hot topic. How do PBMs make money? And also banning income being tied to the cost of a drug, including upcharging, spread pricing, or manufacturer-derived revenues, all circling the wagons around how PBMs make money. And then again, reimbursement at the NADAC pricing plus a reasonable and adequate dispensing fee, which is probably in the dollar and cents world somewhere between that $10 and $11 range. California. And I think this just happened last week. It was unanimously voted through the Senate, and it's requiring the Department of Insurance to regulate and license PBMs. So it's, you might say, well, I thought that was happening already. Interestingly enough, not every state has PBM licensing requirements or even registration requirements. So that's kind of a big deal. Also banning spread pricing and banning PBMs from steering patients to PBM owned or PBM affiliated pharmacies, which you'll hear something that sounds familiar too in just a little bit as we move forward. In my home state of Indiana, House Bill 140 was signed by our governor in last month in May. It also requires NADAC plus a reasonable and adequate dispensing fee. And one of the other things that I thought was really pertinent from this bill is that plan sponsors with 100 or more employees or members cannot have a third party require the plan to use a specific PBM or charge a higher fee for service based on the PBM that's used. So as we see those add-on fees for the use of certain PBMs over maybe the TPA's preferred PBMs, and we certainly know that some of the ASO carriers do have pretty hefty requirements before you can carve out, and all that's changing. So those are good things in my mind. And Trevor, I think you wanted to talk about Montana a little bit here.
Yeah, have to talk about the home state. But yeah, I think one thing maybe to take a step back is talking about why all of this legislation, right? Why are we seeing so much state activity, especially in this legislative session? And you've kind of seen it ramp up over the past probably decade because of a lot of the things that are happening in the market where the old PBM model, if you will, would pay a pharmacy as low as possible and then charge an employer or patient as much as possible and keep the difference. And what that's led to is not necessarily lower overall pharmacy costs, but it's led to um, pharmacies closing at a faster and faster rate. And it's not just independent mom and pop shops, which are very critical for healthcare in Montana, Indiana, more rural locations. It's regional chains. It's, you're seeing it just impact the entire ecosystem. So the question becomes, what can we do to fix it, right? Um, we've been working with partners like TrueScripts for a long time to use private sector solutions to fix it, right? How do we build self-insured plans that are aligned from a cost standpoint, but also reimburse pharmacies fairly? And that's a balance, right? Because we all want to pay the lowest possible cost. But understanding those dynamics that the industry is dominated by three primary players, 80% of the market, kind of helps set the stage and help folks understand, like, okay, this is why it's all happening. And now it's become even a bigger issue federally. So Montana, and we are fortunate just to get eyes on this initial bill as it was going through the House and the Senate. But House Bill 740 got signed into law by the governor. And it really does two things. It kind of cracks down on egregious PBM audit practices. So going after what we would call retaliatory audits. So you would see pharmacies and pharmacy owners get involved legislatively and just magically get the first audit from a PBM they've had in years. And just making sure that when those audits are done, they were fair, right? So some things like it's crazy that you even have to put this into law, but like you can't take back a dispensing fee from a pharmacy when they didn't actually dispense the med. So silly things like that the general public would not know occurs, but pharmacy owners see it all day, every day. And so that's one thing. I think the biggest thing that it did is following some of the other states is setting a minimum reimbursement on medications. So one of the biggest issues we see is under reimbursement, right? So they can't buy the drug for what they can sell it for and make any reasonable profit. So ours is actually a NADAC plus $15 is what was negotiated. And if there's not a NADAC price because there's not one for every medication. Then it goes to wholesale, 100% of wholesale acquisition cost, which again, this gets into, isn't wholesale acquisition cost wholesale acquisition cost? No, there's -6%, there's +2%, all the things that happen in buying. So the cool thing about this bill, in my opinion, fourth generation Montanan, is it's only applicable to independent pharmacies, and those are defined within the bill. So, we probably don't need to help out the Fortune 500 companies
Right.
on their minimum reimbursements, but we do want to take care of our own and those small business owners that, are in the community. So we'll see. I mean, there's always kind of a catch-22, right? We knew that this would increase costs, and that is usually the larger PBM's defense, right? Which is, well, whatever you pass is going to increase costs. Well, the costs are already high, and we know there's a lot of fat in the middle. So how do we work to mitigate and eliminate that while also making sure that we have healthcare in our communities? And these independent pharmacies are the only healthcare in some of these rural communities. So that was a long way of telling you that House Bill 740 was signed. And one of the other issues we see with state law, and you can move on to either Arkansas or Iowa, Lisa, is ERISA, right? So ERISA governs self-funded health plans, typically, unless they're a government plan. And for years, state laws have been passed, minimizing PBM tactics, or supposedly putting guardrails on what they can do. The problem with that was twofold. One is, well, the state doesn't govern all of the health plans that are being offered in each individual state. So you've got the ERISA is a federal law that regulates the self-funded health plans typically, and that's beneficial. Sometimes they don't have to follow some of this, State Department of Insurance, but it's also where a lot of confusion came in, because over the past few legislative sessions, these bills would be passed, and especially independent pharmacists would be like cheering and really excited, and then find out like, oh, this only applies to like 3% of my patients. But it's, it's not something you would generally know. You just think, oh, it's state law. You have to understand how different healthcare programs are taken care of. So that's one thing. And then enforcement is another thing. So I just want to provide some color on these enforcing state law, with the exception of Arkansas House Bill 1150, which will be a little bit easier because of how they tackled it. Can be challenging because you're asking some, which regulatory authority in the state is actually going to enforce the law that's been passed? Do they have enough staff? Do they have enough expertise? And we've seen that a little bit where, it's the Department of Insurance, or, whatever each state calls themselves, right? Who's going to actually regulate and enforce? All of that to say, Arkansas probably passed the most impactful bill that we've ever seen, which prohibits ownership of pharmacies if you are operating as a PBM in their state. Which, if you're not familiar with the general landscape, especially the larger PBMs, well, all of the big three have some level of ownership in pharmacies, whether it be specialty or mail order. CVS is the biggest example of, they own not only specialty and mail order, but they own, 15,000 retail stores. So what Arkansas said is, you can't be a PBM and a pharmacy. You can't be a price taker and a price setter. And so they used the law to basically say, if you have ownership, you got to pick one. You can operate as a PBM in our state, or you can operate as pharmacies, but you can't do both. And that gets away from ERISA, non-ERISA. Just says, I think the Board of Pharmacy that renews licenses is going to check that box and say, you do or don't have ownership, correct? Okay, moving forward, or denied. And so that's what's been pretty crazy about Arkansas. And no surprise, in some of the stats in Arkansas, I think there's 23 CVS pharmacies in Arkansas that CVS Caremark has to decide, do we close them? Do we sell them? Do we stop operating as a PBM in this state? And no surprise, CVS and Express Scripts have both countersued, or sued, I guess not countersued. At this point, they've just sued on the basis of it's unconstitutional and unfairly discriminates against out-of-state pharmacies. So that was a
Big
lot.
one. It's a big one, right?
This is, I mean, not surprisingly, these lawsuits are coming out because if this passes and doesn't, somehow end up in litigation or what have you, you'll see a lot of states follow suit because that's what happens with this type of legislation, right? It's like, oh, it worked in Arkansas. All right, we're going to take that template to the next legislature.
And Trevor, I think it's over 30, maybe 35, 36 attorneys general have already said something to that effect, that they are also looking and watching what's happening in Arkansas with regards to their state. So we may see this be a wave come the next legislative cycle.
Yeah, was it the April 14th letter from 35 plus attorney generals to Congress saying this is a problem.
Yes.
PBMs have too much power. It's not a competitive marketplace. It's not a fair marketplace. And here's some of the issues that are going on. So a lot of light being shown in these areas, and rightfully so. I think we need to shine a light on certain practices that haven't necessarily been beneficial to patients or plans.
Right. Well, let's move forward to Iowa. Also some fun stuff happening.
Yeah, Iowa's interesting. So as of today, not signed by the governor. They do have a deadline of June 14th. So you can imagine in Iowa, there's a pretty big push from the Independent Pharmacy Association to get this law passed. You've got a push from the lobbyists on the other side, the business groups. I think the Iowa Bankers was one group that's kind of pushing back, saying, we can't do this. It's going to cost us, we're already in kind of a crazy economic market. This is going to cost us money. And that's always both sides of the coin, right?
Right.
We need to pay more, but who pays more and how does that all work and how does that flush out? So Iowa, very similar to the bills that UNO releases, NADAC or wholesale acquisition cost plus $10.68 dispensing fee. And that's kind of the mandated floor of reimbursement. At this point, it looks like it applies to every pharmacy. There can't be any, direction for patients, whether that be plan design or what have you, to a PBM owned pharmacy or any pharmacy from what I read. It basically has to be an open and fair marketplace. You pick your pharmacy. Your copays are going to be the same regardless, which, narrow networks or exclusive networks are a way sometimes to contract better and get better rates. So eliminating that could indeed increase costs, but also there's not a lot of plans that take advantage of that. And they're really hard to do in places like Iowa, right? Or Montana, where you might not have a high level of chain pharmacies. So some of the stats that came out of Iowa were that 31 pharmacies closed in 2024. You think, oh man, that's a lot of pharmacies, and it truly is. I mean, half of those were rural, half were urban, and literally all of them, when asked, why did you close? It was like PBM reimbursements.
Right.
So the dynamics of pharmacy purchasing on the wholesaler side and reimbursement on the PBM side create a really unique dynamic and a tough environment for any pharmacy. So
going to have to keep our eyes on that one again, not signed as of yet. Right. So we'll see what happens in the next coming days, because the window's pretty short right now for when that could go.
Absolutely. And that is one thing that we find as a lot of this happens is, a lot of people get excited about bills that are going through and, getting voted on. And sometimes you just got to take a breath, wait, see what the final version is and what's going to the governor's desk. And then you can start going, okay, is the governor going to sign it or not? And if so, what potential impacts are there without anyone having a crystal ball?
Right, right. Yeah, a
But
lot of detail, a lot of things that could change in that short period of time.
oh yeah, absolutely.
All right, well, we're going to switch over to Oklahoma. And, Oklahoma is one of these states where there's been some stuff that's happened for a long time. Probably the first
Yeah.
state that shook it up pretty pretty significantly, because this Patients' Right to Pharmacy Choice Act, it dates back to 2019 when I was doing some research on this, which kind of blew me away. But the bottom line here, and we talked earlier about the impact of ERISA, and how state law and ERISA coincide basically. When does it apply? When doesn't it apply? And so this state and the one we're going to talk about next, Tennessee, are two states where we've seen a lot of activity that I think is starting to provide some clarity around that notion of what does ERISA apply to when it comes to state law. And so
Mhm.
in Oklahoma, this law that was passed, basically it talks about the prohibitions on PBM imposed restrictions on the patient's right to choose a pharmacy. And again, I mean, this plays right into everything we've talked about. Independent pharmacies, in particular, have been picked on when it comes to reimbursement, when it comes to steerage or lack of at the PBM level, especially the ones that do own pharmacies, and they try very hard to keep the business within their walls. And so we see the independents and also some of the regional chains be heavily impacted in that regard. So in Oklahoma, we had this act that was signed, and then it was challenged, as you might guess. Meaning, almost every state law gets challenged, and the district court ruled in favor of Oklahoma, saying that ERISA did not preempt elements of the act, but then the Circuit Court of Appeals reversed that, and so right now where we are is that there's another appeal now going to the Supreme Court. And at issue again, there's three provisions that are determined where ERISA does preempt. So regarding access. So is there geo access type standards, and we're all familiar with those when it comes to the medical side of things. So many miles to so many providers per member, also, with regard to discounts, prohibiting PBMs from providing incentives to steer patients. So, you pay less out of your pocket if you go to this pharmacy versus that pharmacy kind of thing. And then any willing provider for access to your pharmacy network. And that really has become, I think, one of the bigger things as well. The probably indiscriminate reasons that have been applied over allowing certain pharmacies to be in network versus not in network, and also fees and some other barriers and hoops to jump through. So I think Oklahoma is one of the most interesting states. And then now there's also Senate Bill 161, which requires PBMs to maintain a fiduciary duty to clients. I mean, I think we're going to see more and more happening in that way. And so PBMs can't be a fiduciary, but they can apply fiduciary duty to some of their practices. And that's really
Mhm.
what the 161 applies to here. Also, payment parity. To non-affiliated pharmacies as well as affiliated. And if this passes, it's going to go into effect later this year, November 1. So that's Senate Bill 161. But then when we look at Tennessee and McKee Foods Corporation versus BFP, and everyone probably knows McKee Foods, even though they don't know them by this. This is the company that makes Little Debbie snack cakes. So, if it was Little Debbie versus BFP, everyone would really be
We
interested in
know
that
about
McKee.
it. Yeah.
But again, this one, I think this one is one of the findings. Appeals may be forthcoming, but more appeals maybe. This has been appealed. But the Eastern District of Tennessee said that illy willing pharmacy requirement in Tennessee was preempted by ERISA. And so, whether you think that's a good thing or not a good thing, it really does mean that ERISA plays a role in terms of the amount of restrictions. So Tennessee was always viewed as one of those states where you can't provide steerage to a particular pharmacy, and that's really off the table. And so this is, it's becoming kind of
Yeah.
a battle, and we're seeing this played out state by state. Self-funded plans are going to argue that ERISA allows them to follow one set of rules nationwide versus maybe 50 sets of rules, state by
Right.
state. So I think that's pretty important. So, here, in my opinion, here's how things are kind of shaping up when it comes to the state versus ERISA battle. The states are going to be able to regulate like PBM pharmacy reimbursement rates or, acquisition cost kind of rate structures, but they're not going to be able to interfere with how the plan operates administratively, including like benefit design and the structure of those pharmacy networks. So we are, I think, just at the beginning of what we're going
Hmm.
to see again. People watching what's happening in Arkansas, the attorneys general are paying close attention, and rulings like what's happened in Oklahoma, what's happened in Tennessee, it's going to set this foundation going forward.
Yeah, and I think all of this is intriguing and interesting and exhausting all at the same time. But if we think back, and those of you that want something extra to do on Monday, look at PCMA versus Rutledge. That was kind of the landmark case that was like, how much regulatory authority does a state have over a PBM? And PBMs have always said we are preempted by ERISA, for self-funded plans. And that ruling, well, depending on which side you ask, PCMA says, okay, not everything is preempted by ERISA. There's a handful of things that the state can regulate. And some of the states and the pharmacy association said, we can now regulate PBMs. And so shaking out what that looks like is continuing, right? It's one of those
Yeah.
things where, like you said, I was unaware of Tennessee because that was a pretty big deal when we were working with some groups there, and
Yeah.
to see that, what, maybe that's not a strategy you can use because it's preempted, and all have pros and cons, right? So that's the
Right.
thing is,
Right.
um,
But again, keep
all
your
right,
eyes open. Reach out to us if you have questions. I think this is continuing to evolve, and one state after the next probably are going to be picking up some of the bits and pieces of things that we've talked about for almost all these states.
yeah, absolutely.
All right,
All
well, let's
right,
talk about this big executive order.
let's do it. Talked about states. Now let's talk about what's happening at the federal level. So as we kind of mentioned, there was this um, group of attorney generals that sent a letter in April that said, "Hey, we've got a PBM problem. We really urge Congress to look into this." We've seen hearings on it, which have been pretty testy. Um, and then we had on what was that? It would have been the 12th. So May 12th, the executive order came out of um, the United States. Many don't know, pay a substantial share of the overall pharmaceutical market, and we're only 5% of the U.S. or 5% of the world population. So the whole intent of this is to say we we are funding all of the development and research that the world is really benefiting from, and we pay substantially more for pharmaceuticals because of it. How do we even the playing field? And the delivery in the news conference of here's what it is and what's actually going to be is where we need to sort of figure that out. But at a high level, the intent of the law is to say, our other tier one countries pay 40 to 60% less for pharmaceuticals. Why are we overpaying? And we're not going to do it anymore. Now, we're not going to do it anymore is a really difficult thing to say and do based on the pharmaceutical supply chain,
Yeah.
because of a huge, rebates being a primary driver. Um, these other countries that pay less for pharmaceuticals generally have government run or at least government overseen healthcare, so they can truly negotiate with pharma. And we have more of a private sector PBM negotiation, um, type supply chain. I think the biggest issue with the executive order is what was said is we're going to rely on like Europe to pay more. We're going to force them to pay more, and we're going to pay less. Seems like a really challenging, statement and or thing to execute. I mean, obviously, I guess we could leverage tariffs, and who knows where that'll all shake out. But um, the most unique thing, and Lisa, you and I know this because we've been in the business long enough, and we've leveraged for our clients, international procurement of medicine, because it is from the same manufacturer. It just didn't drop into the U.S. with the substantial upcharge. That there are, there's a decent amount of medicine, especially specialty and high cost brands that can be, obtained from Canada, as an example. And many state health plans have kind of embraced that. And so we know that the prices are lower. There's a lot of reasons why those prices are lower. And it's not going to just one executive order is going to all of a sudden fix our pharmaceutical pricing issue. But one of the unique parts of the order is really focusing in on the law that allows for personal importation, and basically saying we're going to continue not to enforce international procurement, right? Because right now there's a big gray area on international pharmacy, and is it legal, is it not? And there's some that are it's black and white, it's illegal. There's some that are like, well, it's gray. And there's others saying it's completely legal, you just can't do it this way, and all across the spectrum. Well, in this executive order, there's a section that's basically like, here's the law that allows for personal importation, and we've basically directed agencies to continually not enforce any of this because we need medicine to come across the border at a lower rate. So that was a long overview of kind of what the intent was. We've got 3 days because they set a 30-day window on what the plan's going to be. Will we see one? Will the deadline be missed? I mean, it's a toss-up. But right now, my commentary is shining a light on all of this is a good thing. Whether anything else happens from it other than just education and bringing more awareness to plan sponsors, making decisions, benefit advisors, like it's all a good thing, even if it's really challenging to keep up with and actually know what's going to happen.
Yeah. Yeah. And again, I mean, how much can we control what other countries do? I think part of this was, let's give drug manufacturers the ability to voluntarily come forward with plans on how they can kind of smooth this pricing out from country to country. And if they don't step forward voluntarily, then we'll take action, which is yet to be defined what that could be. And I don't know that anyone thinks there's any activity happening at all on a plan to bring forward, some parity pricing that's going to cover the world necessarily.
Right. And we tried, or we've tried, we've hit the second round of the Medicare negotiated pricing on high cost drugs. And I think those of us in the industry looked at that and said, that's a good start, number one. Number two, it wasn't enough because most of the pricing we negotiated wasn't even as good as other countries could get. In most cases, right? So it's like, right, it sounded good, but it wasn't enough, number one. And if you took rebates into account on the commercial side, they were a lot of times break even.
Right.
And then what happens when you have this, this interesting healthcare system in America where the government does have negotiating power for Medicare, Medicaid, federal healthcare programs, but they really don't for the millions and millions that are covered under commercial group health insurance by their employers. And so if you squeeze the Medicare balloon, do we start to see increases on the commercial side? It's a very dynamic, quickly evolving marketplace, more so than it's ever been. And yeah, to your point, it's just relying on other countries to pay more is probably not an effective solution, but I'm not a policy expert,
right,
and I don't have a crystal ball, but I also just looking at how our market exists and the big players between state and federal movement, we'll just say it's interesting.
Emily, do we have anything that's been queued up from a question standpoint?
Yes, so Trevor had responded to Ben's comment. I'll read it aloud for everyone, so it might be helpful for other people to see. So Ben had asked, do these state laws apply to employers with employees in these states, or is it simply where employers are HQ'd to what state legislation their plan follows? And then Trevor said, from what we've read, it depends. Most appear to be based on CITES, but others are employees within the state. And then
so
Lisa, oh, go ahead.
Oh, sorry, I was just gonna ask Lisa if she's seen anything else. I mean, I've looked at a couple where it's like it's where the employer is headquartered. I've seen others where it's if you've got employees in any state, it's going to apply. Now, how would they enforce that? I think would be really hard. And then I've seen others that it doesn't appear very clear. So, what have you seen in that regard?
I think it's a great question. I think it's a little blurry in all honesty, but I can tell you the way that we as a PBM view this as, if we have members in a state where there's a state law, then we have to abide by the law. So, our belief is that if we are taking care of members in a particular state that, like any of the ones we just looked at, Colorado or Iowa or someplace where there's reimbursement issue, Montana, that, our responsibility to pay for claims for a member in those states, the state law is going to apply to. So,
Okay.
there definitely could be impacts from an employer standpoint that has employees in multiple states, and it's going to be incumbent on the PBM to apply. But you can rest assured that in a state that's going to have a minimum dispensing fee, for example, of $10 or $11 or $15 for a very low price generic drug, you're going to pay more for that generic drug. And again, there's that payment side. There's also the side that says, we can potentially, I think we're all hoping, preserving pharmacy access, leveling the playing field, maybe eliminating some of the abusive practices. That's all what plays against each other. But that's how we view it, is we have to comply if there's a member there that we're paying a claim for.
Awesome.
Thank you, Emily.
Great insight. Yep. Go ahead, Emily. Sorry, you were going to read another question.
No worries. Lisa Cheek had asked if they will be getting a recorded version of the update.
Yes, I think we're recording this so we can make sure that people get a copy of that.
Absolutely. And then bouncing over to the chat, Paula said, we have Medicare/Medicaid. Doesn't that count?
So I think that might be referring to government regulated costs, like other governments have completely government ran insurance type programs.
Right. Yeah, no, I think that's the delineation, right? We've got a subset of the population that's covered by a federal program, and most of these other countries have everyone's covered by the federal program, which not only gives them more negotiating power, but gives them more control over, how they evaluate drugs and add them to different formularies, how they, every state, if you go through it, or every state, every country, if you're looking at, in the developed countries, has a different way of evaluating medicine. And, candidly, in America, we've got the FDA, and the FDA does not put any type of consideration for approval on what's existing in the market, or is it better or is it worse? It's compared to placebo. So that's also where we, if you look at the pharma lobby and what they've been able to accomplish with the FDA, that's, that they've got their hands all over that. And other countries are looking at it and saying, well, yeah, this drug might be flying off the shelves in the United States, but we're seeing that it's no better than one that's already there, that's already low cost. So either you need to come in at a lower cost, or, that's a hypothetical negotiation, obviously. But so Medicare and Medicaid count, but because we have so many, we've got Medicare, Medicaid, we've got state-run health plans and exchanges, and then we've got ERISA, which is federal, but we don't have all the ERISA plans that could come together and negotiate together either. So that's why we say the supply chain and how everything works in America is just so segregated and
Very
heavily
different.
reliant on rebates.
Yeah. You mentioned the Inflation Reduction Act a while ago, and how now we are starting to regulate some prices, and that will apply on the Medicare side. But there's an impact, on the commercial side. There's obviously a trickle down that will be felt. But I think again, it's the realization from those activities are that number one, it's taken years. We passed it, and we're just getting ready to enforce some of these pricing changes. So it takes so long for things to go into effect. And in fact, some of the drugs on those lists now have biosimilars, or
Yep.
they have their costs were automatically going to be reduced through other means that exist in our system. So there's just the need is just so blatant, I think.
Yep.
Emily, we got anything else there?
That's it.
All right. Well, Trevor, do you have some closing thoughts?
As far as closing thoughts go, I think appreciate again everyone joining us on a Monday. It's a Monday morning still in Montana. I think it's Monday afternoon on the East Coast, but yeah, it's ever evolving. It's evident with all of this going on that we've got a problem. And so we always say there's state legislation, there's federal legislation, all working to kind of solve this problem and all influenced in different ways. But there are private sector solutions out there that are working today. So I've always said if the federal government fixes prescription drug pricing and puts us out of a job, great. At least everyone's paying what they should be paying. The reality is there's so many dynamics at play, and misaligned interests and money that changes hands in the political side of things, that it's unlikely that anything really meaningful will happen. I will say what's being tossed around at the federal level is making PBMs a fiduciary, because right now they cannot be one. They can act in alignment with your fiduciary goals, but a PBM is not a fiduciary. And so what I heard a couple of weeks ago at a conference was that's being tossed around. What if we made them fiduciaries, and they would automatically basically have to act in the best interest of the plan? And that would be unique to 80% of the market. So, but I think it's probably that and rebate reform would be the two biggest things that could happen that could flip everything on its head. Everything else that's happening right now is really just a lot of whack-a-mole and trying to get control of things. So just know that while all of that's going on, there are good PBM partners out there that are doing the right thing, and we can deploy those solutions. So Lisa, I'll kick it over to you to close us out.
Well, I appreciate you joining me, and always your insights and thoughts are so pertinent and really valued in what we do. And I know you're leading the charge in a positive way with all the folks that you represent and are allowed to guide through this crazy mess of pharmacy benefits, and just really appreciate everyone that joined us. I will close with an invitation, and that is if there are other things you want to hear about. And Trevor and I, we could talk probably for hours on almost any one topic. But if there are other things you want to hear about, reach out to one of us or anyone on any of our teams, and we will be happy to set more of these quick chats up with you guys. We really appreciate your time, and we know everyone is strapped and has things that compete for their attention. So just know how much we value the fact that you carved a few minutes out for us today. Have a great week. Thanks,
Absolutely.
everybody.
Take care,
Bye-bye.
everyone.